Hello, everyone, and welcome to the Guthy-Jackson Charitable Foundation Education Center and its NMOSD Grand Rounds. We welcome all attendees, and as we like to point out, the Guthy-Jackson Charitable Foundation is proud to be a source of information about NMO and related conditions. The content of the following presentation is based entirely on published data and expert opinion. The GJCF is not a clinical provider. It does not offer or represent diagnostic, therapeutic, or clinical care recommendations or advice on personal health. All patients and caregivers are advised to consult with their healthcare team for specific information. The goals of NMOSD Grand Rounds include the following points. First, we like to emphasize that this is a practical summary of latest information on a specific topic. The content is designed to emphasize key themes and clinical pearls. The content is also intentionally inclusive of non-specialist audiences. Later in the presentation, you'll see a pocket guide that is a highlight reference of some of the key pearls that you will hear during the presentation. This event is eligible for continuing medical education. The process for earning CME credit includes visiting the GJCF Education Center using the QR code shown here. Select the session and register, view the session, and fulfill the CME requirements and receive CME certification all online. My name is Michael Yeaman, and we are delighted to welcome today Dr. Frederike Oertel. She is an assistant professor of neurology and translational neuroimmunology at Charité Hospital in Berlin and the Max Delbrück Center for Molecular Medicine. She's also appointed at the Einstein Center for Digital Future. She did her fellowship in neuroimmunology imaging at the University of California, San Francisco, and we are greatly appreciative, Frederike, of your time and presentation today.
Thank you so much for the invitation. It's a pleasure to be here. And I'm very happy to present today on the topic of emerging principles and practices for imaging with a focus on NMOSD and its differential diagnoses. These are my disclosures. And the objectives of my presentation are to describe the role of imaging in the current diagnostic criteria for NMOSD, to identify characteristic imaging features for NMOSD, and also to recognize red flags that point to potential differential diagnoses. In the 2015 diagnostic criteria for NMOSD, imaging was actually not part of the requirements for aquaporin-4 IgG seropositive NMOSD, as you probably heard in the last Grand Round talk. However, the criteria, which are still current, include additional MRI requirements for NMOSD patients without aquaporin-4 antibodies and NMOSD patients with unknown antibody status. And in patients with acute optic neuritis, the imaging criteria were an MRI showing normal findings or only unspecific white matter lesions, or an optic nerve MRI as seen up here with T2 hyperintense lesions or T1-weighted gadolinium enhancing lesions, and then extending over half of the optic nerve length or involving the chiasm. In patients with myelitis, as seen here on the right, the requirement was an associated intramedullary MRI lesion that extended over 3 or more continuous segments, also called longitudinally extensive transverse myelitis, or LATM, as probably many of you know, or 3 or more continuous segments of focal spinal cord atrophy in patients with a history compatible with acute myelitis. For people with area postrema syndrome, the requirement was an associated dorsal medulla or area postrema lesion, And for acute brainstem syndrome, the requirement is associated periepidermal brainstem lesions, as you see down here. So now I would like to go through these areas with you and discuss findings for every specific area and how to identify both NMOSD and its mimics. So when we are assessing the optic nerve, most of our patients describe symptoms of optic neuritis. And we would recommend to assess acute optic neuritis with an MRI protocol, including fat-suppressed T2-weighted MRI and post-contrast T1-weighted MRI with gadolinium. It's also useful to acquire optical coherence tomography images. And there we want to acquire OCT ring scans and macular scans to quantify both the retinal nerve fiber layer, or RNFL, and the ganglion cell and inner plexiform layer, or GCIPL, of both eyes. I'm going to talk more about this later. And many centers also acquire visual evoked potentials, or VEPs, in patients with acute optic neuritis. If it's done, this should always be done in accordance with the ISCF standards and should include measurements for both eyes. After optic neuritis, it makes sense to acquire also follow-up imaging 3 to 6 months after the acute phase imaging. So let's have a look at typical findings. During the acute phase, we often see bilateral optic neuritis involving the chiasm. And during follow-up, we then see residual atrophy in a quite broad range, so in 12 to 83% of patients. Compared to NMOSD, in MOGAD, we often also have bilateral optic neuritis, which is retrobulbar and can lead to severe edema, but we often have resolution of lesions later on, and we rarely see atrophy. In multiple sclerosis, the lesions are more focal and smaller, and we rarely see lesion resolution, but we also see focal atrophy in follow-up imaging. So let's look at some actual MRIs. Here you can see normal MRIs in the left column, MOGAD in the second to left column, 1.4 positive optic neuritis in the third column, and then MS-associated optic neuritis in the right column. And when we see a typical case of aquaporin-4 antibody-positive NMOSD, we usually see bilateral optic neuritis. We see this in both NMOSD and in MOGAD, but rarely in multiple sclerosis. The enhancement is usually bilateral and intracanalicular optic nerve enhancement in aquaporin-4 positive NMOSD, whereas in MOGAD and in MS, the enhancement is usually more retrobulbar. Optic nerve swelling can occur bilaterally in NMOSD and MOGAD, whereas it's usually unilateral in multiple sclerosis. However, optic nerve swelling can be absent in NMO. For the lesion location, optic nerve head lesions are very rare in NMOSD and only seen in around 9% of cases. They are much more common in MOGAD patients. In contrast, chiasm lesions are extremely common in aquaporin-4 positive NMOSD and seen in around 64% of patients. They are rare in MS and MOGAD as well. Also common or fairly common in NMOSD are optic tract lesions. And as for the spinal cord, lesions in NMOSD are often longitudinally extensive. Are they in MOGAD? The median lesion length in both aquaporin-4 positive NMOSD and MOGAD is 23 millimeter, which is basically the whole optic nerve. And in multiple sclerosis, lesions are usually shorter. So the median for lesions in MS is 10 millimeter. When we look at the follow-up MRI, as I said before, we usually see this mild residual atrophy in NMOSD, as you can see here. In MOGAD, we also can see minimal residual atrophy, but it's usually less than in NMO, or we don't see any atrophy at all. In MOGAD, we can see lesion resolution. And in MS, we basically never have lesion resolution, and we see this mild residual focal atrophy of this focal lesion. So apart from MRI, as I said before, it's also useful to acquire optical coherence tomography, or OCT, in our NMO patients. This is also a non-invasive technique that quantifies retinal layer thicknesses. And we are mainly interested in the so-called retinal nerve fiber layer, or RNFL, and in the ganglion cell and in a plexiform layer, or GCIPL, that contain the axons and cell bodies of retinal ganglion cells, respectively. And the RNFL is usually measured in a ring scan around the optic nerve head and reported as thickness in micrometer. The ganglion cell in a plexiform layer is usually measured in a volume scan centered on the macular and the fovea. And this can be reported either as thickness in micrometer or as volume. In the acute stage in NMOSD, we can see RNFL swelling, but it's not common. And severe disc edema should always trigger MOG antibody testing, because it's so much more common in MOGAD. Post-acutely, we then see fast thinning of the ganglion cell and in a plexiform layer, and subsequently also of the retinal nerve fiber layer. And the majority of thinning is concluded after around 6 months, at which then we usually perform the follow-up imaging. And in the follow-up, we usually then see the full extent of the quite severe retinal neurodegeneration. This can be unilateral or bilateral, depending on the optic neuritis. And we see the thinning of both the RNFL and the ganglion cell in a plexiform layer. And it's important to mention that the thinning in NMOSD usually doesn't have a temporal predominance, but as you can see here, it's quite homogeneous, homogeneously distributed around the optic nerve head. And as you can see here on the left side, we usually see quite normal RNFL and GCIPL thicknesses compared with healthy control cohorts in eyes without a history of optic neuritis. But then we see quite severe damage after the first episode, and even more damage after subsequent episodes in NMOSD. When we look at multiple sclerosis, the atrophy is usually less severe, and we see this temporal predominance of the RNFL loss, which is quite characteristic for multiple sclerosis. In MOGAD, we usually have a similar atrophy pattern. So we also usually see homogeneous atrophy of RNFL and GCIPL, but we usually have less damage per episode, but more episodes. So now I talked a lot about multiple sclerosis and MOGAD as differential diagnoses, but obviously when we see a patient with a first-time optic neuritis, we should also consider other differential diagnoses. And one of them is infectious optic neuritis. As you can see here, this is a really nice flowchart published in a review article, and that can help you distinguish infectious causes of optic neuritis. Usually, we see different patterns of optic nerve involvement, and also associated phenomena like neuroretinitis, papillitis, retinitis, or choroiditis that can help us distinguish these causes of optic neuritis from, for example, optic neuritis in NMO or in other inflammatory diseases. Here on the top, you can see a case of papillitis and granuloma, and here in the bottom, you can see a macular star, as we usually see with neuroretinitis, for example, in cat scratch disease or rickettsiosis. Optic neuritis can also occur in systemic inflammatory diseases, and since they also have some overlapping symptoms with NMO, it's important to consider these. One of them is sarcoidosis. In sarcoidosis, we usually see anterior or retrobulbar optic neuritis with a lumpy, swollen optic disc, and we sometimes also see granulomas with retinal detachment, which can help us distinguish this from NMO. We also often have retinal involvement in different forms of vasculitis. However, in vasculitis, we see ischemia way more often than actual optic neuritis. And there we see branch retinal artery occlusions, leakage, and exudates. So here you can beautifully see the ischemia, and here you see the acute inflammation around the vessel, and here you can see old leakage around this vessel. These are all very characteristic for vasculitis. Now moving on to the next location, the spinal cord. Clinically, patients suffer from symptoms of myelitis. To assess the spinal cord either during an acute attack or when you want to diagnose a patient with neuritis optica, it makes sense to perform a sagittal and axial T2 weighted MRI and post-contrast imaging. And it's always good if you have a complete visualization of the spinal cord. And then follow-up imaging should again be performed 3 to 6 months after the acute phase MRI. During the acute phase, we usually see single or multiple intramedullary T2 hyperintensities involving the gray and or white matter, and acutely we usually see contrast enhancement. And then during follow-up imaging, we see a fragmentation into shorter lesions, and sometimes we see resolution, although that's rare and again more common in MOGAD. Persistent enhancement is also rare and only seen in around 12% of patients with AQP4 antibody positive NMO. And but focal atrophy is seen quite commonly both in NMOSD and in MOGAD. So how do the images actually look during the acute phase? The lesions in NMOSD are usually located in the cervical or thoracic spinal cord, and this is actually not useful for differential diagnosis. But if you see a patient with conus involvement, this should trigger testing for MOGAD. So when we look at the lesion length, I think everybody knows that longitudinally extensive transverse myelitis, or LETM, is very characteristic for NMO. However, we also see short T2 hyperintense lesions in NMOSD. They're often centrally located, and they occur together with T1 hypointensities in 14 to 50% of NMOSD patients. However, most of the patients with short lesions will subsequently have longitudinally extensive lesions. And they are obviously way more common, occur in up to 90% of recurrent cases, and they can include focal cord swelling and also concomitant T1 hypointensities in around 70% of cases. When we look at the axial imaging, we often see a central pure gray matter involvement or mixed gray-white matter involvement. And since it's transverse myelitis, it's usually affecting over 50% of the cross-sectional area. There are some key findings you should pay attention to. One of them is the H sign, as seen up here. These are T2 hyperintensities that involve the spinal cord gray matter, and they're actually quite commonly seen in MOGAD in around 30% of cases, but they can also occur in NMOSD. The other, even more characteristic phenomenon for NMOSD are these so-called brighter spotty lesions, which have a T2 signal intensity higher than CSF and can occur in 30 to 50% of NMOSD patients. When we look at the enhancement pattern, lesion enhancement in general is quite common and often longitudinally extensive, patchy, or ring-like. However, it rarely persists longer than 3 months in NMOSD. And usually we see this lens or ellipsoid-shaped enhancement in NMOSD, which can be helpful because in multiple sclerosis, it's usually more ring-shaped. And longitudinally extensive leptomeningeal enhancement is possible, but it's actually not common in NMO. So during the chronic phase MRI, I again showing you examples here of MOGAD on the left side, NMOSD in the center, and multiple sclerosis on the right side. And in NMOSD, we usually have a reduced lesion size, and we see residual atrophy in the axial imaging. In MOGAD, we characteristically see fully resolved lesions or strongly reduced lesions and no atrophy, whereas in multiple sclerosis, we see a reduced lesion size and new interval lesions. So to sum this up again, a fragmentation into shorter lesions within 3 months, or resolution can happen in NMOSD, but is more common in MOGAD. Fragmentation, actually, we see a lot. And persistent enhancement is rare in NMO. However, focal atrophy is quite common in both NMO and MS. So obviously for LATM, we should also consider some important mimics. One of them is, again, sarcoidosis. Here you can see the images in the bottom. Sarcoidosis can involve the central gray matter and the dorsal columns with dorsal enhancement. We characteristically see this trident sign on axial imaging, and often we also see intense homogeneous dorsal subfield meningeal hyperintensity and contrast enhancement. And extremely important, the enhancement usually persists for more than 6 months. So this can help you distinguish these diseases as well. Another important differential diagnosis is GFAP. In GFAP, we usually see less edema. We see multifocal punctate or leptomeningeal enhancement, and we often have concomitant encephalitis. And last but not least, we also have paraneoplastic causes of longitudinal extensive lesions. These usually appear linear and involve the dorsal or lateral column, and they are quite commonly tract specific. Some systemic inflammatory diseases can also lead to myelitis. I listed some important ones here. Antiphospholipid syndrome usually leads to thoracic myelitis, Bechdel syndrome to multifocal longitudinal transverse myelitis, Sjögren to progressive transverse myelitis, sometimes also acutely, lupus usually to myelitis of gray or white matter, and systemic sclerosis to subacute or progressive myelopathy. All of them should be considered mimics of myelitis in NMO. However, they usually have a quite characteristic clinical phenotype, which can help you distinguish them from NMO as well. I listed this here on the right side. And obviously, there are also non-inflammatory causes that should be considered as differential diagnoses of myelopathy. Here are some common ones that also can affect the demographic typical for NMO. One of them is spinal cord infarct, seen here on the left, which mainly involves the gray matter, can lead to this anterior linear enhancement, and usually also leads to homogeneous axial enhancement. Copper deficiency involves the bilateral dorsal columns and leads to this rabbit ear conformation seen down here. And we rarely see contrast enhancement. Spondylosis affects many patients, and obviously you usually have the lesion under the level of maximum compression, and you have this transverse enhancement, so-called pancake sign. Another important non-inflammatory differential diagnosis are fistulas that usually lead to this focal lack in homogeneous enhancement pattern on sagittal MRI, also called missing piece sign. And last but not least, gliomas, or in general, neoplastic causes should be considered as differential diagnoses. Here we usually have this more diffuse involvement in the axial imaging and homogeneous enhancement, and in glioma specifically, we often see an increased uptake in FDG PET. So I hope these are some signs that can help you distinguish non-inflammatory causes from myelitis. Here the clinical picture is actually quite diverse. It can include aria postrema syndrome, other brainstem syndromes like vertigo and diplopia, narcolepsy, seizures, encephalopathy, and also focal symptoms. When we want to assess brain involvement in NMOSD, either because of some specific symptoms or in the diagnostic workup, it again makes sense to include T2-weighted imaging, as well as FLAIR imaging, fluid attenuated inversion recovery sequence, and post-contrast imaging. And follow-up imaging after an acute attack again makes sense 3 to 6 months after the acute phase MRI. However, a surveillance MRI in remission is usually not recommended. And I'll tell you in a second why. During the acute phase, we see brain lesions in up to 80% of NMOSD patients. And here you see some typical locations, obviously the area postrema that is known to many of you. And we also often see lesions posterior, abutting the fourth ventricle. We see lesions in the corticospinal tract and in the splenium corpus callosum. We often see non-specific lesions in the subcortical white matter and also linear ependymal enhancement. And during follow-up imaging, lesions are usually smaller, but still present. And we sometimes see additional subcortical interval lesions. So I listed them in a table as an overview. Area postrema lesions are located in the dorsal medulla, and they can be subtle or transient. They're not always seen with the clinical area postrema syndrome, and we also don't always see enhancement. Other brainstem syndromes usually are caused by periepidermal lesions around the cerebral aqueduct or the fourth ventricle, and these lesions are seen in up to half of our patients with NMOSD. We can also see lesions in the hypothalamus or thalamus or at the anterior border of the midbrain. However, they are rare in NMO, but still more common than in multiple sclerosis, so they favor a diagnosis of NMOSD. And then there are a number of other brain lesions we should be aware of when we image NMO patients. Typical lesions are located in the cerebral peduncles, in the corticospinal tract, and we sometimes also see large hemispheric lesions in the white matter, although this is more common in MOGAD. We quite often see small unspecific lesions in NMOSD. And we sometimes see cloud-like lesions, but they have a similar frequency in NMO, MOGAD, and MS, so they're not really relevant for differential diagnosis. In contrast, tumefactic lesions and leptomeningeal enhancement is more common in MOGAD and should trigger MOC antibody testing. So this is how it looks at the actual images. Here we see an area postrema lesion. Here in B, we see a lesion in the dorsal pons abutting the fourth ventricle. Here we see the periepidermal lesions with ependymal enhancement on top. And in the bottom, we see a lesion in the splenium of the corpus callosum. And then in E, we see this multiple small non-specific T2 lesion in subcortical white matter. So when we look at important differential diagnoses, we again want to focus first on MS and MOGAD. I think everybody has seen an MRI of a patient with multiple sclerosis, and there we usually have these multiple small lesions, typically, for example, in pons, periventricular, or white matter. We sometimes see ring enhancement. We also sometimes, like seen here, we also sometimes see the central vein sign, as you're probably aware. And importantly, we often see interval lesions in multiple sclerosis, which are less common in NMO. In MOGAD, lesions are usually poorly defined, and we sometimes also call them fluffy. I think when you look at A and B, you know why. We also often see leptomeningeal enhancement, as seen here in C, and also often extensive cortical lesions in MOGAD. Okay, so during remission, the brain T2 lesions can resolve in MOGAD quite commonly. They less commonly resolve in NMOSD and rarely in multiple sclerosis. However, we often see a large reduction and progressive fragmentation in NMOSD. And new or enlarging asymptomatic lesions are extremely rare in NMO and MOGAD, and they should always point you in the direction of multiple sclerosis. And if we see lesions, they're usually small, unspecific lesions. So let's look at some cases. Let's start with this patient. She's a 42-year-old woman. She has been healthy, and now she describes a 2-day history of left visual blurring and pain with eye movement. I saw her acutely. Her visual acuity was reduced to finger counting in her left eye, but she had a 20/20 vision in her right eye, and she had a mild optic disc swelling. And actually, when you see this case, it would already be atypical. Such a strong visual acuity reduction is uncommon for multiple sclerosis. And so we performed an MRI brain, which only had unspecific lesions. The MRI spinal cord was normal. However, we performed visually evoked potentials, and she actually had a conduction block on the left side and P100 latency of 105 milliseconds in the right eye, which was normal. 2 days later, we got our labs back, and she actually had a positive antibody for ACP.4. And here on the right side, you can see the OCT after 3 months. So let's look at the OCT a bit more closely. Here on the left side, you see a report of a ring scan. And on the right side, you see a report of a macular scan. When we look at the ring scan report, you see on top the scan itself. And when you get this report, it makes sense to make sure that the scan is focused correctly on the optic nerve head and that it's well illuminated. Then in the next image, you see the actual segmentation of the RNFL layer. And here again, you can just check the quality of the image to make sure that you can trust the values. Then below, you see the thickness profile of the patient's eyes in black on a background of age and sex matched healthy control cohort. And I apologize that the legend is in German. So if the purple area means that it's thick, that it's above the 99th percentile, so it's too thick, then blue means borderline high, so above the 95th percentile. Green is within normal limits. Yellow is borderline thin, below the 5th percentile, and red is definitely thin, so below the 1st percentile. And then below this, we see the thickness of the retinal nerve fiber layer for the different segments. So for the superior, temporal, nasal, and inferior segment. And she has never described symptoms in the right eye, and that's also reflected on her OCT. This is all green. We don't expect that she had an involvement of the right optic nerve. However, if we look at the left eye, we see this thinning of the RNFL, which does not have a temporal predominance. And since this is at 3 months, we would assume that there is more thinning to come within the next months until around 6 months after optic neuritis. So this is a quite typical case of optic neuritis in NMOSD. Up here, you also see the asymmetry between both eyes, and you see there's a quite strong difference between both sides, which also again points you at severe damage done to the optic neuritis eye. So the report for the macular, you can interpret quite similarly. So up here, you see the scan itself. You can check if it's centered correctly, if it's well illuminated. And then here you see the thickness in black and the volume in red for the different segments. And actually here, we depicted the thickness of the complete retina, not just of the ganglion cell and inner plexiform layer, but I'm sure you can appreciate the difference between the right side and the left side, which already points towards a thinning of the ganglion cell and inner plexiform layer as well. How would a report look in important differential diagnoses? Here on the left side, you see an RNFL report from a patient with multiple sclerosis who had 2 optic neuritis episodes at 2 different time points. But you can, I think, appreciate that she had temporal thinning in both eyes, and that in general, the thinning is much less severe than it was in the previous patients, which you can understand by looking at this G in the middle, which is the average RNFL thickness of this eye. Then I brought another example of a patient with Susak syndrome, rare vasculitis. And here, when you look at the OCT, you already see this inflammation around the vessels. You already see the leakage. And then when you look at the reports For the macula down here, you see that it's severely thickened in the right eye more than in the left eye. So I think when you look at the OCT, there's no question that this looks very different and that this is not an optic neuritis episode. Okay, let's look at typical patient number 2. She's a 34-year-old woman, and she presents to the emergency department with a 2-day history of progressive worsening back pain, difficulty walking, and sensory changes in her lower extremities. She denies bladder and bowel incontinence, and she does not have any history of visual changes or any other neurological symptoms. In the exam, she has a moderately severe paraparesis and a loss of vibratory sense. Her MRI brain and orbit or optic nerve is normal, but her antibodies also came back positive. So, and I think when you look at the spinal cord MRI, you can beautifully appreciate the longitudinal extensive transverse myelitis, both up here and then also down here, where you see already a bit of a fragmentation. So some differential diagnoses we discussed previously, but just to refresh your mind, we should, for example, consider AV fistulars as a differential diagnosis, spondylosis, as seen up here, and then also all types of neoplasms, as for example, epidymoma, as seen here on the right side. Okay, the third case, actually, I stole from this beautiful case report. She's a 72-year-old woman with a history of breast neoplasia and rheumatoid arthritis. And she describes a 4-day history of nausea and painful toxic spasms in her left arm and left leg. They last around 10 seconds and occur 2 to 3 times per hour. She does not report any falls. During the exam, they noticed a subtle left hemiparesis and increased left deep tendon reflexes, as well as a positive left Babinski. Her EEG was normal, and her CT and PET excluded paraneoplastic origins. However, if you look at her MRI, I think it's quite clear that she has this bilateral anterolateral medullar and upper cervical spinal cord lesion, hyperintense in the FLAIR sequences in sagittally in A and also in coronal plane in B. So I think this is a very beautiful example for an area postrema syndrome. And with this, I would like to summarize that we would suggest a new onset suspected NMOSD to perform MRI brain with and without contrast, if available, and also MRI cervical and thoracic spine with and without contrast, if available. Obviously, it would be preferred to have imaging of the whole spinal cord. And then if you see a patient with optic neuritis, we would recommend to perform MRI orbit with fat-saturated images with and without contrast, if available, and OCT. There's actually less evidence to perform visually evoked potentials, but it can be considered as a secondary option if MRI or OCT are not available or inconclusive. If you see any of the following findings on imaging, this should always trigger testing for aquaporin-4 antibodies. So if you see lesions of the posterior optic nerve or optic chiasm, especially if they're longitudinal extensive lesions, and if you see bilateral involvement of the optic nerve with severe retinal degeneration without temporal predominance, that points towards NMOSD. So do longitudinal extensive sagittal T2 lesions of the spinal cord, especially if they show bright spotty lesions. And for brain and brainstem, very characteristic are ependymal enhancement, lesions abutting the third and fourth ventricle, especially but not limited to the area postrema. So what should point you away from NMOSD? What are red flags? If we see persistent enhancement for more than 3 months, this is quite uncommon for NMOSD, and so are new or enlarging asymptomatic T2 lesions. Resolution of lesions is definitely more common in MOGAD than it is in NMO, and short spinal cord and optic nerve lesions can occur in NMOSD but favor multiple sclerosis. and severe optic nerve head swelling during optic neuritis favors MOGAD over NMOSD. So I summarized all of this in a pocket guide for you, and I'm happy to answer further questions either now or also by email later on.
Frederike, thank you so much. That was an excellent review of imaging pearls in NMOSD and related conditions. Let's move to a few questions, Frederike. These are often asked in the NMOSD community, but also beyond NMOSD specialists. So one question, we can start with OCT. If OCT is conducted externally, beyond one's institution or a specialty practice, what specific details should be requested as being included in the report?
Yeah, I think this is a question I get quite often. The best solution would be to get the whole report of the OCT imaging, as I have shown you today. If this is not possible, I would definitely suggest a report that includes both the RNFL and GCRPL thicknesses for both eyes, as well as other potential ophthalmological and neuro-ophthalmological findings or findings that point towards comorbidities, for example, glaucoma or other findings like edema. Yeah.
Great, thank you very much. And if one is considering serial MRI and OCT imaging, should that be performed? And at what interval would you suggest?
Yes. So I think from our practice with multiple sclerosis patients, we are quite used to performing, for example, annual MRIs, since NMOSD patients rarely have interval lesions. It's not necessary to perform quite regular MRIs or OCTs. So I would definitely suggest to perform both MRIs and OCTs during the acute attack, as well as follow-up MRIs 6 months after, but it's definitely not necessary to perform regular MRIs during attack-free intervals.
Great, thank you. You emphasized the longitudinally extensive characteristics of lesions in NMOSD, both in the optic nerve and in potentially spinal cord. For the spinal cord lesions or the optic nerve lesions, short, hyper-intense lesions, let's focus on the spinal cord. Short, hyper-intense lesions in the spinal cord, are they exclusive of conditions other than NMOSD, or are they specific and can be seen in NMOSD?
Yeah, also a great question. LETM is, I think, one of the characteristic features of NMOSD, and so for many providers, short myelitis seems very uncharacteristic of NMOSD. However, both short myelitis and short optic nerve lesions can actually occur in NMOSD and don't exclude a diagnosis of NMOSD. And most of these patients usually have longer lesions later on.
Excellent, thank you. You also emphasize some particular characteristics about imaging in NMOSD. For example, post-event atrophy is not uncommon in NMOSD. And as compared to MOGAD, where spinal cord lesions often resolve, they may not with NMOSD. Given those differences, can imaging be used to predict long-term disability likelihood or functional outcomes in NMOSD?
Yeah. So unfortunately, we currently only have data based on cohorts and no data for individual patients on the predictive value of imaging. So as you mentioned, we know that, for example, focal atrophy or severe thinning of the retina obviously leads to worse both visual outcomes and also motor and sensory outcomes. But unfortunately, there is not yet a predictive value of imaging features on a single patient level. Maybe in the future.
Yeah, thank you for that, Frederike. And I think there's one other question here. So given the information you described, what are the emerging sort of future forward-looking imaging techniques that are promising for potentially improving diagnostic insights and or managing the disease going forward?
Yes, so this is an extremely active field, and we have both new acquisition methods and also new post-processing methods every year that we are evaluating for the diagnosis and management in NMOSD, MOGAD, and multiple sclerosis. I think I can just pick two. The one sequence, MRI sequence, that is already used in clinical practice and seems to be of value is the STIR sequence, which can help us identify optic nerve lesions, especially when contrast cannot be given or is not available, contrast agents. And another new acquisition method for optic nerve imaging is the OCT angiography, which has shown promising results, especially in distinguishing NMOSD from vascular causes of visual disturbances.
Frederike, there are a couple of other questions that we'd like to get your advice and expertise on. Oftentimes, patients will ask their physicians whether the lesions that are seen on imaging, be they MRI or OCT, whether those will heal, whether those will resolve, and particularly regarding visual lesions. Can you offer some expert perspectives with respect to, do these lesions go away, and is vision and disability permanent?
Yes, so patients ask me this question a lot, and we obviously see axonal damage and ganglion cell damage, for example, on OCT, or also neuronal damage and atrophy in spinal cord lesions. And on the other hand, we also see demyelination, for example, measured by VEP. And the demyelination can actually improve. We see remyelination in patients with neuritis optica, patients with a conduction block due to an inflammatory optic neuritis, for example, often have a recovery. Also, we see often a shortening of P100 latencies over months and years. So this can definitely recover to some extent. However, neuronal damage, both axonal and damage to cell bodies, can currently not be recovered. And interestingly, we even see a structure-function mismatch. So when we compare patients with NMOSD and patients with MOGAD with comparable neuroaxonal damage, we actually see that patients with NMOSD often have worse functional outcomes compared to patients with MOGAD. And we do not fully understand this yet. However, on a patient level, it's definitely also worth mentioning that there's always a recovery of function also due to the adaptive potential of the visual pathway and also other brain regions. So, for example, especially with the visual system, patients can learn to focus with areas other than their fovea and therefore improve their central vision also for months and years after their optic neuritis episodes.
Thank you, Frederike. One other question relates to patterns that you might have noticed between demographic cohorts. For example, do you encounter differential patterns in male versus female patients, or in older versus younger patients?
Yeah, I actually thought a lot about this question. Currently, there are no systematic analyses comparing different age groups or male and female patients in terms of their disease severity or their imaging features. Also, there are many patients in Asia, and their imaging phenotype is often different from the imaging phenotype in white patients in Europe or North America. This is another point we haven't fully understood yet, and we're actively researching. However, recently a publication came out in 2023 looking at spinal cord lesions in pediatric patients with NMOSD for the first time, and described a quite similar picture to adult patients with NMOSD, which is reassuring.
Frederike, thank you for that. One last question I'll ask you to speculate on or provide specific examples, but do you experience in your practice differences in imaging patterns at acute onset versus relapse events?
Yeah, that's an important question. We investigated this for optic neuritis episodes and saw that subsequent episodes often cause less neurodegeneration than the first episode. There are multiple potential explanations for this. One explanation might be that we have less neuronal content left, so that the percentage damage is the same. Obviously, another potential explanation is that disease-modifying treatment helps ameliorate attacks and attack severity.
Those are great points, Frederike. Again, we really thank you so much for your expert opinions and experiences, and I'm sure the audience will greatly appreciate these as well. Thanks again.
Sure, it was a pleasure to be here. Thank you.
We want to remind everyone that the presentation you just saw is eligible for continuing medical education. To register and receive continuing medical education, please visit the GJCF Education Center using the QR code shown here. Select this session or the session that you are interested in and register. View the session and fulfill the CME requirements, and then receive CME certification all online. We also want to remind everyone that the NMOSD Grand Rounds series contains highly informative information summarized in a very useful way. And you can see we've had Dr. Dean Wingerchuk talk about diagnosis and differential diagnosis. Dr. Frederike Oertel today talked about emerging principles and practices for imaging. And next will be Dr. Jeff Bennett talking about therapeutic decision-making, rationale, and transition. We really appreciate everyone's interest in this new series, and we would point you to the GJCF Education Center, which contains information about NMOSD Grand Rounds, other educational events, and many different presentations and useful media. We would like to thank Alexion and the AstraZeneca Rare Disease team for sponsoring the GJCF NMOSD Grand Rounds. It is greatly appreciated, and we support the idea of education improves patient care and outcomes.